The article that I chose to talk about is published in the Journal of American Society on Aging. It was published this spring of 2020. It's called Connecting Models of Care to Address Elder Mistreatment by Shreen Alshabasi, Benjamin Lezick, Amy Berman, and Terry Fulmer. I chose the topic of elderly mistreatment or elder mistreatment because it is something that we go over in theory, but not something that we technically get to experience in the clinical setting or experience before we actually become nurses. We only had 2 days in clinicals, so it's hard to comprehend sometimes a topic if you don't experience it firsthand or if you don't know what to do or how to detect it. I feel like this topic is really important in nursing or in the nursing practice, because elder mistreatment is a worldwide problem. It may be different in every single culture or depending on the area, but it is a problem that is worldwide. We have an increasing growth of the elderly population right now in the United States. 20% of the population is 65 years or older, and of that 20%, 5 million elderly people actually experience some type of abuse or mistreatment. The World Health Organization defines elder mistreatment as a single or repeated act or lack of appropriate action occurring within any relationship where there is an expectation of trust, which causes harm or distress to an older person. This includes carelessly doing acts or knowingly doing acts to harm the other person or the older person physically, mentally, financially, and emotionally. And sometimes it can be difficult to even recognize or detect warning signs when taking care of patients because it is not something that is out in the open. But the mistreatment or abuse or neglect is not only coming from healthcare providers, but also it can be the patient's partner, family members, or even strangers. And a lot of these cases are never reported. There are different frameworks that can be used to detect and prevent elderly mistreatment in different care settings, but this article specifically covers the 4M framework, which is a holistic framework that was created by the Age-Friendly Health Systems Initiative. And the 4M stand for the first one, what matters, medications, mentation, and mobility. And each of these M's has a specific role in identifying mistreatment or abuse in the elderly. The first M is what matters, where you can identify the goals that the adult has, whether that be short term or long term, and you can determine if they're being inhibited by the people that are taking care of them. And this by possible mistreatment, which can be, denial of access to resources such as food, medications, social isolation, not taking them to follow-up appointments. The second M is for medication, in which the provider basically determines or de-prescribes medications that interfere with mentation and mobility, and this is mostly benzos, opioids, over-the-counter sedatives, because we know that some of the elderly mistreatment done with medication can be either over-medication or withholding medication. Something that is very common, especially in long-term care facilities sometimes, is chemical restraint, where patients are given medications to stop bothersome behaviors. And then that goes into the third M, where mentation and dementia are addressed, or any other type of mental health concern is addressed. In hospitalized patients or even outpatients, the goal is to prevent, treat, and manage the mental health concerns to decrease dependency on others. And then we go into the fourth M, which is mobility, and the goal of this is to create a plan to improve function and support of what matters to the patient. So it kind of just goes back in a circle. Nearly 1/3 to 1/2 of those over 65 have trouble walking, and some interventions that providers can do or nurses can do is giving them the resources to assistive devices such as walkers, canes, etc., or managing pain if that's what is a barrier for them, or even suggesting exercises. This 4M framework is best used in emergency care settings only because there is no time for the abuser and the person being abused to get stories aligned or to suppress evidence of abuse. That also means physical evidence of abuse. In primary care settings, it can be easier to detect elderly mistreatment, but only because there's a close relationship sometimes between the patient and the care provider, but there is lack of training in that area for physicians. Close to 11 cases of elderly mistreatment are reported by healthcare providers, but only 1% of those 11 are physicians. And there is a study mentioned in the article that was done in 2012 in which 23 healthcare professionals were interviewed and asked why they failed to report, and the results of this indicated that the physicians stated, or the healthcare providers stated, that elder abuse is important, but it was not a priority at the time of care, and also it's not something that is most commonly encountered only because it is hard to detect sometimes. In long-term care settings, on the other hand, the mistreatment can be different, and it can be coming from either the staff or the residents, usually from resident to resident abuse or mistreatment. It's mostly verbal mistreatment, not much physical mistreatment, but there was a case or a study mentioned in the article from 2016 that they did in a New York nursing care facility where 2,000 people were asked if they have ever experienced any type of mistreatment in the care facility, and over 400 of them actually stated that they did from other residents. And it's dependent. Every case is different, but there's no specific single solution for elderly mistreatment. But it is important that us as healthcare providers or as nurses, even nursing students, improve this issue by staying alert, paying attention to inconsistencies in stories about either accidents or patient care, or even the resources that are available to them. Each case varies in severity. Some may be very obvious, the bruises, the scratches, the no alignment in stories, but in others, it can be hard to detect. So interventions need to be carefully considered, communicated, and collaborated with other healthcare professionals, especially in hospital settings, because it is possible that you might be able to put the patient in a more problematic situation. But as future healthcare professionals, or even just a person, I guess, we are the safe space. We are the point that can disrupt the cycle by just thoroughly assessing and intervening and using this framework in hospital settings to identify elderly mistreatment.